Hi.
Perfect. All right. Maybe I'll wait a couple more minutes.
Danny, I was thinking for the shared folders, are they ready to be shared? Like, because I know you said you were going to migrate them over to the POCUS Gmail. Are they ready to be shared yet, or do we need to kind of finalize that before putting a link out?
I mean, they have to be migrated. I still haven't finished migrating them over, but I
Yeah,
mean, like, if Kevin can just migrate them, it looks like there's not much in them. So, I mean, like, as long like the stuff that's already in there should be ready to go.
gotcha. Okay. So all we'll have to do is maybe send out a new link once everything is done. Okay, cool.
Yeah. And
Great. Thank you.
I was gonna send an email, like our quarterly email anyways, with all of our
Mhm.
stuff, and I was gonna include that link.
That's
Because
perfect.
I've made a template for our case reviews.
Oh, awesome. I'm excited. Excited for your case.
Yeah, it's not a whole lot, but it's a little something. I have technically two, but some learning cases. So let me share. Make sure everybody share my screen. Hmm. So I'll see what we have. Hello. Hi, Scott.
Hey, I'm on the procedure team this week and I don't have anything going on right now, so I just am hiding in our closet.
I love all the supplies in the background. Excellent.
Yeah, yeah.
Let me see who else we have. Okay. I might give it until, should we give it one more minute and then I'll just get started?
Sounds good.
Okay. 1 minute is up. Okay. Hi, everybody. I'm Danny Russell. I'm part of the leadership group for PHM for our POCUS SIG, and today is our first case review of the year. So we stayed within line of soft tissue. So I have two kind of shorter cases. But we'll kind of talk about like the probe that was used. There's just kind of a template that if anyone in the future wants to go through cases or they want to have a dedicated case review, that is something that we have something that's kind of standardized for you throughout. And next week when I send out our kind of quarterly like updates email, I will be including the link to our drive that has that included, and we'll have like the cases and that sort of thing. So the case I have today, I'm just for some background. Again, my name is Danny Russell, and I'm from Children's Hospital of King's Daughters in Norfolk, Virginia, which is essentially Virginia Beach, and we have a standalone children's hospital, and we're with EVMS, but we just joined with Old Dominion University. So we are an academic center, just kind of nestled up there, just under Inova, next to Lake BC Richmond. So I'll start with some clinical context. So this was a 15-year-old female who was admitted for cellulitis that failed outpatient treatment, came in for cellulitis with a questionable abscess. Initial ultrasound that was diagnostic did not show any abscess at the time, but it was over the right anterolateral foot. It was over the ankle, and then it extended down into the foot. Did not get better with clindamycin, was admitted for IV antibiotics. That morning when we saw her on rounds, she was having more swelling, pain, and then she wasn't sure the resident that morning was not sure if they appreciated fluctuance. And so on physical exam, there's definitely some erythema. It was extending a little bit past the line that was drawn the night before. Some swelling, no discrete fluctuance, but with the way the foot was angled, it was kind of hard to tell of was it just generalized swelling or was there maybe an abscess forming. So our question for POCUS was abscess or no. So as you know, with POCUS, it's answering yes or no questions. We're not doing a diagnostic image. We did use the initial diagnostic ultrasound kind of as a baseline, just so we had an idea. But otherwise, we kind of were going in a little bit blind. We were maybe comparing to previous, but they're two separate not types of images, but they were a little bit different. So, okay. So how did we acquire the image? So we used my butterfly probe. So for those of you who don't know what a butterfly looks like, it's just all one probe. So it can look like you can do high frequency, low frequency. You can do, I actually have it in here. So you can do some linear and soft tissue imaging. You can also do some cardiac, and you can do some abdominal. So you have it's can be fairly flat, but then you also have a little bit of that curvilinear aspect to it. So if you want to see deeper structures, you can. With the butterfly and with other machines, there are different presets that you can use that are at a set, because you have your basic frequency that you use based off of the probe you choose. But with like a computer-based probe, it is based off of the preset itself, because it's a chip, not the actual crystals that are within the probes if you have like a cart-based system. So at first, I was playing around. I wasn't sure if I was going to use the musculoskeletal preset or the superficial vascular preset, which changes both your depth a little bit, and then it also can change your resolution some. So we started with MSK. We're not really seeing what we wanted, and then switched to superficial vascular, but I have images from both of those presets. We didn't use a discrete protocol, so like with lung, with like a blue protocol where you look at different things. But with soft tissue, you want to look at your image or your item of interest in at least 2 different planes. So we did do that. But there was no abscess that we could, spoiler alert, sorry. So we didn't check it in 3 orthogonal planes to get the volume. But if we did, that would be something that we did. And then the other thing that we missed is we did not get Doppler. So we trialed 2 different depths, and then you guys, and then we can talk about what kind of, what the quality of the image is, and then would you guys have maybe chosen the same type of probe, a different setting? So we can kind of have a discussion at that point. So this is the first image. So this is the anterior lateral area of the foot. Oh no, this is my good one. Can you guys see? Okay, so this is the first image. And so at this point, feel free to shout out what you're seeing. Good image, bad image, issue with depth, issue with image quality, issue with gain. I guess we can talk about the depth first.
Yeah, it looks like there's some wasted space at the bottom of the screen. So I would say, it seems like your structures of interest are between the scan and 1 to 2 centimeters. So we could probably chop off a few centimeters at the bottom.
Exactly. So we did go ahead and do that. And we switched to superficial vascular, which gave us a little bit more. The gain was a little bit up, just a bit. So this is in the longitudinal plane. We were trying to do a compression test when you could see that drop there. And this is me trying to go into the transverse plane over top. So I'll just play it once and then I'll go back through. So what we're seeing here is kind of classic for cellulitis. So it's called cobblestoning because you have the hypoechoic fluid and swelling that is in between that subcu fat, which creates kind of a cobblestone appearance. You can also see kind of a little bit up at the top some inflammation and swelling, and then knowing in terms of what your gain might be looking like. As long you want your hypoechoic areas, you want that to be black. You don't want it to be like that light gray. You don't want to be overexposed essentially, and you don't want to be underexposed where things are too dark. So on that short axis plane, we were seeing that classic kind of cobblestoning, but no discrete area of abscess. So no area. There was maybe we were concerned on this right through here that there maybe was an abscess kind of snaking through, but when we flipped, it was just simple fluid. And then this is us trying to compress at this point. So we also started directly over the feet bones, for lack of better phrasing. And so you can see when you are, that you can't see anything past the bone. So this is like super basic. So bone is not going to, you're not going to be able to get past that. So, which is part of why there was so much dead space down here as well on the other image. So you've got your bone through here, and then you're seeing all of your superficial soft tissue right here. So in terms of quality of image, or in terms of what you would like to see in a good image, what things might you guys see? Or what things would you guys like to see better of?
So Fabian, did you want to, looks
Yeah,
like you
hey,
unmuted yourself. Did you want to chime in? Hi.
yeah, probably comparing your first image with your second image, I think that you gave us soft tissue much better. And that's pretty much what we want to do. I think that the second image, like the first one, first one that is in your screen, but the second one that you showed us, gives us pretty much all the information, or most of the information that we need to be convinced or not about diagnosis.
Exactly. So from that, what we decided is we held on surgical consultation. The cellulitis was not grossly unchanged, and we compared the diagnostic image. There wasn't more hypoechoic fluid. There wasn't more fluid in that cobblestoning when checking the similar area to the radiologic image. And so we went ahead and did not consult surgery, or did not decide to go forward with like an IND. And then at the same time, we found out that the outpatient dosing for their cellulitis was subtherapeutic, so they didn't even fail outpatient treatment. So slightly unrelated, but an end to that case. Any questions on that one? Just kind of simple, straightforward.
Yeah,
I was just,
yeah, sorry, go ahead, Andrea.
Oh, I was just gonna add, sometimes in these settings, one thing that you can add to your protocol is also just some probe compression of the area in question, particularly that area that looked like maybe it was like early, not organized abscess, because you might see like the pus particles kind of displaced. We call it, I call it squish sign. I think Scott calls it swirl sign. What Scott calls it something else. But essentially just like displacement of those fluid particles, the pus particles, that can tell you that maybe there's an early abscess developing that may or may not need drainage, but it can be helpful to kind of keep an eye and look at it as it evolves over time. Sometimes it can also indicate, so if you see the particles really displacing deep down into like, or crossing fascial planes, it can indicate like a deeper infection.
Awesome. Thank you.
The only thing I was going to add was it might be helpful, like on the foot, my anatomy is maybe a little shaky, and so I would probably try to compare to the normal side if I was able to get the patient to cooperate, just so I had like a frame of reference for the level of edema and fascial thickening and that kind of stuff.
And I usually I didn't save the normal on this exam, but I do the same thing where I'll look at the non but first and then go to the next one. I did have a quick question. In terms of like doing iterative exams for something like this, do you guys mark the area where you like mark the area in question and try and look in that same spot each day? Or is it just kind of like on a case by case basis on what you do? And if you're trying to look at iterative exams on how the cellulitis is progressing, or if you see an early abscess, to try and make sure it's standardized.
I haven't done that, but that's a pretty good idea. Yeah, especially like if there's an area you think looks like it's starting to coalesce, then I think that's definitely a good idea to like mark it on the skin, and then you come back and look at the same spot.
Or if like the night person is going to take a look at it because it got suddenly worse, they aren't seeing something else instead. Okay. Okay.
One thing that I was taught back in my country with ultrasounds was that if you are not very convinced about like fluid collection due to inflammation versus an early abscess, many times the early abscesses will give you like a posterior acoustic enhancement, and inflammation would not. So like and absolutely, that's precisely what they did. They used to do, kind of mark the area, try to see if there was like a developing posterior acoustic enhancement or not in the area that we were concerned of or about, and then yeah.
No, that's great. That's really helpful. Yeah, and if going back, you can see that there was no. It's kind of harder to tell, but there was no posterior acoustic enhancement there. And in terms of like marking the image or just showing when it's compressed, when you guys are looking at loops, because I'm kind of compressing here, but when you guys are marking it or putting something on your image, do you say like, do you do one that's non-compressed and then you do another loop that is like, and this is where I do compression? Or do you just kind of include it in your description when you are looking at when you're doing these?
I can't say that I've done it systematically. I always compress if I'm concerned, if I want to make sure that there's not an early abscess formation, but I probably wouldn't save a clip if it didn't show a significant finding. But then I would make the comment in the report, no, no squish sign or no fluid displacement on probe compression or something like that.
Okay.
We also have a butterfly, and what I do in the note part, especially when I save it as a draft, is putting like the time that I'm doing the compression, right? So at 15 seconds I did compression or something like that, just for me to know that that is the moment that I did my compression.
I guess one other quick comment I would just add for the recording purposes is just the lack of specificity of cobblestoning, that it's really something that you want to take within the clinical context. So it just really is a sign of inflammation and edema within that subcutaneous tissue. So other things like soft tissue edema from heart failure or from an allergic reaction or something like that would also cause that same finding. So although it can be helpful in diagnosing cellulitis, it's not like a pathognomonic finding.
Great point. Okay. So anything else for this one? Okay. So the next one I have is more of a foreign body, but I didn't know if anyone had any other images that they wanted to bring up before. I just have a second case just in case. So I didn't know if anyone had one that they wanted to talk about or bring up.
wanted to and was supposed to, but we are having QPath difficulties on this end, so I'm sorry. But I will show you all for fun later because it's kind of cool at some point.
I have some random clips, but if you have yours up, I'd be, I feel like you should just keep rolling with it. You took the time to prepare, so I think I'm excited to see what you have.
It's again not very big, but it is something that kind of has another point in terms of what happened with this patient in a way that we don't typically, I don't typically see foreign bodies on the hospitalist service, but it's something that we were kind of able to see something quick within this same vein. So this patient had a guanfacine overdose. They thought they were hypotensive. Well, they were hypotensive, and then the family went up on guanfacine at the same time a day after the patient had her Nexplanon placed, and they thought it was related to the Nexplanon, and she was having some pain around the site. But because of her kind of how much adipose she had around her arm, it was kind of hard to tell. There was no overlying erythema, but they were worried that the site was infected. So when we did the exam, it was on her left upper arm. It was very limited. It was very hard for us to completely palpate where that Nexplanon was, and it was tender to palpation. But again, no overlying erythema. The insertion site had healed by that point. So, but the family was still very, very concerned, and so partially for learning purposes and to kind of help quell the family's anxieties, we looked at the Nexplanon on ultrasound to assess for signs and swelling and potential questionable infection around the Nexplanon insertion site. So again, we used the butterfly probe on a high frequency setting. At this time, I did the superficial vascular as well. Depth was at about 2 centimeters. I did do it in both the longitudinal and the transverse plane. I was able to get at one point the longitudinal plane, but I do not have a safe clip of it. So I just have the transverse, but it's also, you're able to see kind of the artifact that's on that image. And again, I did not check with Doppler. I don't know, and this is a question for you all as well, unless I'm overtly concerned for something that needs to be vascular or not. Like if it's like a lymph node, then I will typically do Doppler, but for just kind of run-of-the-mill cellulitis or kind of really just cellulitis, how do you guys always use Doppler, or is that just a case-by-case basis as well?
It's usually not that helpful, to be honest. But it can, like if you see discrete fluid collection, it can help rule out things that are vascular. And then it might also lend some credibility to the idea that this is inflammatory because you might see hyperemia around it versus, like Andrea was saying, cobblestoning is non-specific. It just means fluid is in that sub-Q space. And, you know, if it's not infected, I wouldn't expect like as much hyperemia, I guess. So, but it, like all of that stuff is sort of couched in your clinical assessment of that patient, and ultimately you're making clinical diagnoses. The ultrasound is just sort of helping to push you one way or the other.
Yeah, I kind of agree with Scott. I would put Doppler whenever I see a discrete fluid collection, and definitely if you're ever considering doing an IND, always putting Doppler before.
But not as part of your everyday protocol, of course.
I mean, I still do. But you know, whether if it's less helpful in the setting of cellulitis, I think I just out of habit, I always sort of take a quick look. Whether I save it or not depends on, you know, again, if there's a discrete fluid collection. But yeah, I think just out of habit, I do the 2 views and then Doppler.
There's some nuance to that too. Like, you know, power Doppler is another Doppler setting that doesn't give you information about direction of flow, just velocity. And that can be more sensitive for things like hyperemia. Not every handheld is going to have power Doppler. but all of them have color now, and it's an easy thing to do quickly. And so maybe just like a 2 or 3 second clip, you could look. And then the other thing to keep in mind sometimes is the scale that you're using, depending on your setting. On the Doppler, it might be like overly or under sensitive. And so it's a setting you can usually change, like the speed at which it's picking up flow. And so all those things make it like a little bit trickier to interpret, but yeah, I think it's reasonable to just put it on there for a couple seconds, save a brief clip, and especially if it's something you're going to put a needle or a scalpel in.
It's really helpful. Thank you. So, and it's the power Doppler will be slightly different from like because on Butterfly, which is kind of I guess the one that we're talking about the most, is that's different from low flow and high flow?
I think that Butterfly does have power Doppler. It just shows you like an orange, kind of an orangey color for everything, as opposed to the red and blue flow. So you don't get information about which direction things are moving, like that, the red toward blue away. It's just like all that orange, but it's like there's a scale on the screen that shows you like that, like the lighter orange it is, the faster it's moving, or the darker, the slower. So it's helpful for things where you're just looking like for hyperemia, you don't really care about directionality. It's just, is there blood flow around it?
That's awesome. Thank you. So when looking at the findings, it was on the left inner arm, longitudinal and transverse. This is unfortunately only the transverse. So we move us over here. And we were limited a little bit by habitus. And then again, I did get it on longitudinal, but I wasn't able to record. So tried to line it up right in the middle of the screen. The 2 centimeters were very superficial. It's right up here. And you can see that posterior enhancement. You can see that shadowing, not right now, but just go back to the beginning because I lose it and then I bring it back, which is also right there in the middle.
And did you say in the case that they thought that it had been removed, or it had not been removed?
It had not been removed. They were worried that there was lots of inflammation and swelling around it, and they were worried that it was infected or there was like a pus pocket there. So we did not think so clinically, but also it was technically limited by habitus, so we just took a peek. So it's just able to quickly, and there's no cobblestoning, there's no like from what we could tell, no no hypoechoic fluid around it, no abscess that we could see on the transverse view, but again, no longitudinal, but on the longitudinal, there was not one. So again, in terms of like what you're going to look at, if you're going to look for a foreign body, is like trying to line it up directly in the middle. I do have a lot of dead space there. So moving up the depth would have been more ideal so I could get it in the direct center of the screen as opposed to just like seeing at the top and saying, oh, this is what we have. So, but another way to quickly to kind of evaluate, oh, this is a foreign body and not something that is, a vessel or something else along those lines.
But
So
I think in defense of your clip, it's also really good to get a forest for the trees view and to be able to see, depth, to make sure there isn't something posterior. So I think for an initial image, I don't think that that's a bad thing necessarily to have some increased depth. But then I would probably get a subsequent image that just zooms in on more on that area in question. So both have value in different ways.
Yeah, you could think about it like a scout film on when they shoot that X-ray before the CT. So this is like your initial image is your scout film, and then you can clean it up if you need to focus on what you need to focus on.
just remembering like you can have multiple clips to show multiple things as long as you're trying to figure out to get to where you want to go.
Yeah.
Help you
It's funny too, like now I feel like I use only machines or my like GE handheld, and it cuts you off at like 3 to 5 seconds or 10 seconds at most. And the Butterfly, I remember, lets you record up to a minute, and so we would just end up with these really long clips. Like Kevin would be so mad at us for he's like, what are you doing for 30 seconds? You saw the thing and then you just keep so it's it's funny. I'm having PTSD flashbacks to fellowship.
Yeah, sorry. There's definitely a point where I like take it off and it's completely black. And I'll have times where I'm like at the bedside and I'll be doing the image and I'll be recording and I'll be talking to the family and I look down and I'm like, "Ah, I'm still recording." It's going to be nothing. So I'm going to have to edit that out later. But yeah, it's a blessing and a curse
I
to have a
remember
loop.
doing that. Yeah. I remember doing that a lot, leaving the recording on and then be like, I guess I have a minute of nothing, just like 5 seconds of skin.
I was reviewing all my initial images here with Duncan, and like he would be like, "What were you looking at?" And I couldn't figure out why, because his machine doesn't beep; it just does the 4 to 6 seconds, and he has it silent so it doesn't make noise. And I'd like scan, I knew what I was looking at, and everything was horrible. Well, Duncan scans retrospectively, so when he finds what he wants, he hits it, and it takes the previous 4. And so all my images were totally, it was bad. It was bad, but we have that fixed now. But it was like, I couldn't get an image of anything I wanted, and I'd go back to review. I'd be like, what the heck is going on here?
This wasn't it. What are we doing? That's really interesting though, too, of like how people, how some people are going to look at things retrospectively and some like once I get it, then that's when I'm like, okay, I see what I want and I'm going to record. So there are pros and cons to both, I feel like, depending on your patient's willingness to cooperate. But, so that is all I have. We did not remove the Nexplanon, and we reassured the family, and that was it. So again, it was just a way to show foreign body, something pretty basic and kind of straightforward, but within the soft tissue realm. So that is all I had. I didn't know what other images people wanted to bring up.
Do you have any idea about like how she evolved? Like, did it resolve? Did she continue to have pain?
She
I know
had
it's hard in the hospital setting.
we did we also put a little bit of an ACE wrap for some support just because there was some just with movement there was more, and but when she had her arm up and was kind of chilling and having it in that sitting like this, it was much more comfortable. And when we ACE wrapped it, there was kind of that support there. I think it just wasn't moving around as much. Was much more comfortable, sent her home. The family did eventually want it removed just because they were convinced that the hypotension that she experienced from the overdose on guanfacine was actually the Nexplanon. But I think they had to wait like a month from the outpatient side to get it removed. But at the follow-up visit, I did look, she was no longer having any tenderness or pain to that area by the time of follow-up a week later.
Mm-hmm.
So yeah, if there's anything else that you guys wanted to, I mean, I know this was the first time that we've used that review template. And I know in terms of looking at image quality, there might be some questions that we might want to be asking people, or specifically for images, or, you know, what type of artifacts or what things in particular you wanted to point out that we can put on the template in the future. Or if we want to keep it more kind of laid back like this.
I thought this was great. You know, I think I'm just looking at sort of the people on this call, and I think most people are not complete POCUS novices who are on this call today. So, you know, maybe when we have a larger group with a more variety in terms of how POCUS knowledge, really review. But yeah, really going over like this is the top, this is the bottom, this is the left, this is the right. But I think in with this audience, it doesn't sound like we need to do that.
Sounds good. Yeah, I think, oh, go ahead, Scott.
I was just gonna say laid back's good.
Yeah.
And so, yeah, I didn't know in terms of like choosing a case, I wasn't sure if it was something that was more basic and straightforward or something really cool that like, oh, I, popped a linear probe on, this kid with a pneumomediastinum and I saw air and I was able to see that, or something different. Like I didn't know how, like which kind of case would be better to pick. And so I guess it can maybe depend on the week, the month that we have. So. Cool. Andrew,
Yeah, I thought this was awesome. And it's nice that it builds on what we talked about last time too.
And so I guess that's another question for people who want to submit cases is, does it have to be based off of what was, taught about the month before to reiterate, or can it be anything?
I think we can have like one or two queued up that are relevant to the last thing that we taught on, but then people can share whatever they want.
Yeah.
So we'll just have some stuff ready in case nobody brings anything to share. And
Well, does anyone have anything interesting or cool to share? Anything else?
Danny, would
I
you?
can pull up another foreign body if you want, but I was trying to, looks like the sharing is disabled.
Let me see. I should have been able to. Let me see if I can get it.
You guys see that okay?
Yeah.
Cool. I obviously didn't do a PowerPoint. This was a kid who was in the hospital for totally unrelated neurological complaints who was kind of limping around the room. And Duncan had this patient first. I took over after and was like, what are you limping around for? And she stepped on something on the ground, hurt her foot. He took a look and clinical exam was consistent with cellulitis. So they prescribed her Keflex. She had a cut on her foot, red, erythematous, all the things, prescribed her Keflex. She ended up being in the hospital for quite a bit. And I took over the following week and he had talked to me about it. And she was still limping, still having pain, had a big old kind of hypopigmented healing lesion on her foot. And so we decided to take ultrasound to it. So this is in the transverse. I can pull the others, but scanning through. And this is on the bottom of the foot, right in the middle. So after talking to her a little more, and I'll see if I can freeze it right around in this area. Froze on me. After clarifying the history, she thought she might have stepped on glass. And so you can see you've got that thickened skin on top. And then you've got this artifact, that ring down reverberation artifact coming down. And so after talking to her, she thought maybe she stepped on glass. And this seemed pretty consistent with it. So we ended up opening up that little section and pulling out a shard of glass that was in her foot. So this was, again, transverse. We did both. We applied Doppler, everything. There's no abscess. There was no increased flow to it. There was no squish sign. Given the history, it's with a linear probe on a GE venue. So ended up being extremely handy on the inpatient side.
Yeah, nice.
Trying to pause it right in the spot, but it's being super funny when I click. I don't know why. Nope. There you go. There's Doppler, and there was nothing. You ready, Andrea?
I think so. Hold on a second. Okay.
So, Andrea, while you're pulling those up, I think for some of these case reviews and stuff, POCUS Atlas Peds is looking for a lot of images. I ran into someone who is one of the like moderators for it, and they're looking for lots of normal images and then interesting images as well from the Peds side. And I got their contact info, but if you guys are wanting to send any of those their way, they are definitely looking to build up on the Peds side, which I know for a while now, but they're, I guess, making a dedicated effort and they have something on their website that has a link, right?
Yeah. I think there's a way through SonoClip Share to send the images that you upload to the POCUS Atlas also. And if you just designate that they're PEDS images, I'm sure they would find their way to the PEDS POCUS Atlas thing.
Okay. So this is just to contrast another foreign body. So this was actually in an adult, but so he was, I think, construction worker and had had some discomfort for a couple of days. And this is the palm of the hand. So again, so most superficial is the skin, and then you can see sort of in the subcutaneous tissue. So, and then deepest here, there's a bone with some shadowing behind it. And then in the subcutaneous tissues, you can see that there's definitely some thickening. There's some sort of irregularity and a little bit of cobblestoning sort of in the deeper part of the tissues over here. And then this was the area in question that was causing pain and swelling. So you can see kind of, this is the longitudinal, you can see a very sort of discrete linear, without posterior, there's no significant like shadowing or reverberation artifact. There is like a little bit of surrounding sort of hypoechoic appearance, which is probably edema. Sometimes you can see that if the foreign body has been present for quite some time. And then let me share the Doppler with you.
Be a good image for teaching in plane ultrasound guided needle placement.
Yeah, you're right. It looks a lot like a needle. In this case, this was actually a wooden splinter. And so like one of the values of ultrasound is, you know, for all of those organic materials like wood, or like thorns or plant-based materials that don't show up on X-ray, it can be very helpful to use ultrasound. And so then just going back, so this was with color Doppler, so you can see there's a little bit of surrounding hyperemia. You can see in particularly sort of above the foreign body, but then within this area, there isn't any vascularity. So this was removed without any complication, and he was very happy. If you look at the sort of the measurements on the side, so you can see like this is like at least like 1.5 centimeters, so it's a pretty big foreign body.
Would hurt.
Yeah.
Awesome. Well, any other images y'all want to share? We've got about 12 minutes left if we want to go for the full hour. If not, that's okay.
I had two quick ones. I'll just show you an example of the power Doppler for hyperemia, and then one where it looked like it could have been infectious, and the color Doppler revealed that it was probably just a superficial like thrombophlebitis. So top top image was what I saw initially. This patient came into in fellowship, it was kind of like an urgent care clinic, and they had this like swollen lump on their forearm, and they said it hurt and it was a little bit red. And so looking at it with the ultrasound initially, in that top image, and then the bottom one, you can see that there's some blood flow around it. And then I don't remember, I think now it's in long axis, and you can see there's like this kind of organized clot inside the vessel there. And it's like a little bit swollen around that area. So I don't know how that happened. You know, if she like bumped her forearm and that caused damage to the vessel, and it led to that. But the other one I was going to show you was just this example here. So there was cellulitis, and I was looking for a drainable fluid collection, and this is like pretty undergained probably. It looks really dark. But you can see just a little bit of cobblestoning in that subQ tissue, and then with the power Doppler on there, it just goes from this like redder color if it's not flowing as quickly, and then it's really like bright yellow if it's flowing fast. And you just see like that kind of speckling around the infected area, indicative of that hyperemia.
Oh, that's really cool. That's really helpful. I'll start using that.
Cool. Thanks for putting this together, Danny. It was awesome.
Thanks. So we'll do another one, not next month, but the month following. So sounds good, guys.
Thank you very much.
Yeah, that was great.
Fabian, it was nice to meet you, man. I hope you come
Nice-
back.
Nice meeting
Yeah.
you. I will be in everything I can.
Right on.
Awesome.
And make your residents come too.
Yeah, I will force them now. You need to go.
Yeah.
Thank you.
Cool.
It was super interesting. Thank you very much.
Yeah. See you guys.
Take care.
Bye, everyone.